There is no one else?
Yeah, I think Dr. Jayaprakash joining. I don't know. He'll come.
Okay, let's start. Okay. So, I mean, complication of the disease and one or two words about the complications of the treatment because he's taking this medication for 3 months. He also said that he's feeling tummy pain and all that. Okay, now another very important point regarding illness like this, in which joints is involved. And I think the MRCPCH people, they are very much into it, especially when they talk about the CP child or anyone in which the functional area are involved, like in this case. So you need to ask a bit about the functional class, that how much, like you ask about 0 to 10 pain thing, but you also need to ask about the type of the involvement of the functional system, that how much he can work, like is he able to sit, can he walk with support or without support, can he go up the stairs, can he go to the washroom by himself, can he eat by himself, can he dress and undress by himself, can he comb himself, can he wash his teeth by himself. Like this will tell you about the severity of the illness. You can ask one or two questions in these five
Right,
six.
right. Functional assessment.
Then one thing which is very important, I think we should learn this sentence, especially for the CP and anyone with movement disorder, that because of this illness, is there any change in the furniture of the home or anything which you have placed on the wall for the support, anything like that? So it will also give you about the, because this is something which is creative, and I think these people, the English people, they like these things when you
Yeah.
ask, because you're more going into the child.
Not only diagnosis, like we need to assess the severity and the history should have been,
Exactly,
should also help us to
exactly.
plan the treatment. Not only the medical,
That's it.
non-medical treatment also. That's
Yeah,
also
that's it. Yeah. So I
Right.
think this was my feedback about the history portion. I think the way you did was excellent, but there is always a room
there.
for
Room for
improvement.
improvement is always there,
Yeah.
and actually
So if you know, yeah, if you know a lot of angles, so on the day of exam, under stressful condition, under spinal
right.
reflexes, not the cerebral reflexes. So if you remember two or three things, it will help out.
Okay,
Right.
thank
Right.
you. Thank you, Dr.
Very
for
nice
giving the
feedback.
feedback.
Yes.
Yeah, thank you.
Good feedback.
So, Dr. Hiren, that
Yeah.
Dr. Jay wants to do his video first because he had some work.
Okay. Okay. Fine. No problem. We'll
And Pankaj
do
is
for
not
him
there,
first.
so you can take his video.
Yeah. Just I will add few more points. Just the
Hmm.
diagnosis was JIA. It was not rheumatoid arthritis.
Hmm.
Hmm.
Okay. And I would consider is one of the very good attempt. I mean, within a short period of time, doing all the things, doing full PGALs and complete history is very nice only. Regardless of the few, I mean, it was not comprehensive history and focused history. So you ask very nicely, other than the taking too much time on acute history, something important point which Dr. Tahir mentioned, like home modification, weight loss, because there
Hmm.
was some finding, Peller was there, so weight loss history was expected to ask,
Yes.
and there was difficulty in writing and other stuff. So functional history also was expected to ask, like he has writing, combing, and other area of
Hmm.
functions. Okay, so
So,
excellent.
so what would be
Uh,
differentials here apart from the JIA?
GIA, rheumatoid can be like leukemic, septic arthritis, could be this reters, reactive arthritis. But
What is the
reactive
intent?
reters, this,
Hmm.
it will be like a short duration. It will not be for 3 months. So 3 months, mostly GIA, rheumatic, or kind of psoriatic if there is a rash and all. And hemophilia or bleeding disorder also, it will be, there will be some clue will be there, otherwise no need to consider that.
Okay.
Okay, so we'll go for the video.
Pankaj was supposed to do the video.
Pankaj is supposed to prepare as a candidate, right?
Yeah, yeah.
Or role player. If
Candidate
Dr.
role player is
Jaiprakash has
Dr. Jaiprakash. Candidate now Dr. Tahir can take the as a candidate because Tamanna's candidate you will be. So everybody will get chance.
yeah, it's totally
No,
fine, no problem.
actually, I have already prepared one case because today I was supposed to present one video. So Dr.
Yeah.
Tamanna, she was my candidate. So if
So I
anyone
will
is, yeah, if because it's a simple case, not a difficult one. So
no
anyone can
issue.
be a candidate.
I will play candidate for your case. You become a candidate for Dr. Jaiprakash case because Pankaj, I think, has not joined.
Okay, okay.
So he has already posted these pictures in the group. So Dr. Jaiprakash, you have to guide the time and you have to ask all the question. Okay.
Time I'll keep
Okay.
6 minutes. Time I'll keep whenever you start. I will 6 minutes.
Yeah. Let him review for 3 minutes and.
Okay. Dr. Tar, 3 minutes, and you just have a look at these two pictures. And 12 years, this old boy has presented with this fever for 2 days, for last 2 weeks rather.
Okay, 12 years, fever for the last 2 weeks,
Yes,
and these rashes.
yes, this is the picture. These two pictures.
Okay, okay. Let me see the pictures. Okay.
Tahir has left or what? खतरनाक पिक्चर है डॉक्टर जय प्रकाश.
Network problem probably.
पिक्चर जोरदार जोरदार ले आया था भाई. गैंग्रीन है पर पूरा फुलमिना से क्या है?
ये डिस्कस ही कर लेते हैं. ये ताहिर नहीं आता तो अपन ही डिस्कस कर लेते, कोई बात नहीं. ये क्या ऑब्जर्वेशन है? व्हाट यू ऑब्जर्व?
Infective endocarditis.
वेरी गुड.
Looks like infective endocarditis. There is a gangrene
मेरे
and
दिमाग में
there is a
एक ही
kind of a
डायग्नोस आता है. मेरे
splinter.
को ये नहीं आता है बिल्कुल डिफरेंशियल डायग्नोसिस.
Yeah,
Hello.
Dr. Tahir is there.
You can
So
start.
Yes, I am back. Actually, I don't know. I am on the roof. I don't start it, or I can start now.
start. Yeah.
Okay. So just let me take the picture. Yeah. So I can see I can see a picture showing a hand and both feet of a child. There is a blackening of the index finger of the hand, which is a distal part is involved. There is I can also see a scaling over this blackening. Rest of the hand appears normal. I can see the feet. There are scattered area of blackening of the feet, especially of the digit, the third digit, the big toe, and the little finger. On the little finger, there is also a bit swelling and redness around this black swelling. So this is my findings, which I can see.
What do you think? What it is suggestive of?
With fever and these black spots, I can think of that it is a sort of gangrene secondary to, it is a dry gangrene secondary to bacterial infection. Secondary to infection.
What other the diagnosis come in your mind? Differential diagnosis you will keep?
Yes, it can be secondary to infections. It can be secondary to vasculitis. It can be secondary to thrombocytosis. There can be protein C and protein S deficiencies if this is recurrent. And on the bottom of the list, it can be a vasculopathy secondary to chronic disorders like diabetes, but it should be long-standing. But in this scenario, I would stick to most likely secondary to infections.
What is most likely for diagnosis? Infections?
Yes, infection, most likely. Dry gangrene involving the index finger and the digits of the lower limb secondary to infections.
Okay. This I can give you clue to arrive at the diagnosis. This child was operated at the age of the 6 weeks of this congenital heart disease. Then what comes in your mind?
Sorry, I did not heard, sorry.
This child was operated, at the age of 6 months for the congenital heart disease.
Congenital heart disease.
Yes, then what do you think? What comes in your mind?
So it can be the distal vasculopathy secondary to infective endocarditis, like the Genevieve lesions or the infective vasculopathy secondary to infective endocarditis.
Okay, very good. What additional history you will get?
We should ask about recent appearance of the murmur or changing murmur in the heart. We should do a complete examination, especially the cardiovascular and that of the abdominal examination to look for the spleen And we should also look for the other signs of infective endocarditis, like the I'm forgetting the name, I'm sorry, but the lesions under the nails, and we should also check the I think that's it.
What general physical you will find? What clinical sign you will find on the general physical examination?
Yeah, on the general physical examination, we should look for anemia,
Very
and
good.
we should look for the genital lesions, and we should look for the splenomegaly, and we should check the blood pressure. We should check the temperature. As you said, it's he's febrile, and we should check the lymph nodes even.
What investigation would you
And
order?
also we should check the distal pulses.
Okay.
Yes.
What investigation you would perform?
Investigation, the most important is the blood culture. We should do a blood culture on at least 2 or 3 culture on different space of time. We should do a simple CBC. We should do an echocardiogram or the jelly scan of the heart, and we can do the ESR. It will be raised. The CBC, it will show us anemia, and we can do ECG. We can do chest X-ray. But I think the most important is the blood culture.
Okay. How would you manage this patient?
Management is mainly medical. It can be surgical. But first of all, we can classify it as like a journal, like in which we will just do the give painkillers, and we can just lower down the temperature. And if there is heart involvement, just elevation of the head end. Then we can give antibiotics for these infections. The antibiotic will depend upon the type of the culture organism which we are getting. And if we do not have an organism, so we can start the prophylactic antibiotics, most likely to cover the Staph aureus. We will give it IV, and it depends upon, we can give it for weeks, at least 3 to 4 weeks. We will give it for weeks, especially 3 to 4 weeks, but we'll change it according to the type of organism we are having.
You expect what common organism which are responsible for infective endocarditis?
Staph aureus, Staphylococcus aureus, and its different types.
Any other organism apart from?
Yes, there can be Streptococcus, there can be MRSA. Depends upon the type of the valves. It is the native valves, it is the infected valves, if it is the replaced valves. So the organism will be different. Even it can be Pseudomonas. Even it can be Pseudomonas, it can be Streptococcus, it can be Staphylococcus, it can be Streptococcus epidermidis, the skin flora organism, and it can be MRSA. So all the treatment will depend upon the type of the organism.
Very good. What complication you anticipate in infective endocarditis?
Infective endocarditis complication, it can be the cardiac complication, and it can be the peripheral complication. The peripheral complications, which we can see even in this child, that we can see that there are different peripheral gangrenes. There can be splenomegaly, there can be anemia. The cardiac complications, it involves that they usually involve the different valves. So the type of the valve which will be involved, so the symptoms and the presentation will be according to that. But there can be arrhythmia, there can be cardiac failure, and the
Why arrhythmias? You will develop why arrhythmias?
arrhythmias because there will be turbulency in the blood of the blood flow, and there can be overload in any chamber because of the narrowing or because of the regurg of the blood. So that's why there can be arrhythmia.
Can you tell me the highest group for infective endocarditis?
Yes, the children who are having the dental extractions, or who are having splenectomy, or who are immunocompromised children, they are usually, or any children who is undergoing surgical procedure, or who are having involvement of the aortic valve with having vegetations, they are a higher risk group, or who are the IV drug abusers, or anyone with immunodeficiency conditions.
Okay. I think we took. I think time finished, Dr. Sandeep.
Double time. I told twice. Time's finished.
Yeah.
Actually, I'm not listening. I'm on the roof, and the signals are not that good.
Listen.
Uh-huh.
Okay. Sorry.
Dr. Prakash was in full mood, so I thought like let's.
He caught me in a topic which I never. I always skip this topic. I don't like this topic.
And also, once we go for this pillar, at that time anemia, we should also look for this any retinal hemorrhage. Sorry, this retinal hemorrhage, and as well as petechiae. Retinal hemorrhage are root spots, that is on fundoscopy we will see. But on general physical examination, we will see this petechiae and this anemia you told, and this ossular nodes, Genuelian you told, splinter hemorrhage you missed. And as far the
Yeah, I forgot the name of this splinter hemorrhages.
yes,
This much is expected during exam actually.
yes, whether they are tender or not, this side is tender or not, rashes, whatever, that is important question in the history, whether it is tender or not, that we should also ask. Joint pain is also important, and any previous history. Just I told you, but we have to ask in the history if any previous history of the congenital heart disease or any intervention done. So, and also this as far investigation is culture, sometime also if there is involvement renal environment, so also urine dipstick, they may present with this hematuria also, proteinuria. So, and streptococcus viridans is more common as compared to the staphylo, as you elaborated the main list, MRS, pseudomonas, that we can manifest, that we can encounter in any of these conditions, but specific is streptococcus viridans and the subsequent also staphylococcus aureus, and this regimen is for 6 weeks, this broad spectrum, and also sometimes we may find gram negative in IV drug abuser, and that depends upon the cause, as you told, to be given around gentamicin for gram negative cover also, in addition to this gram positive cover. So these were the few. So overall you did well. Ultimately you arrived. However, you were at
Good.
yes.
Okay, we
Very
have
nice,
10
very
minutes
nice.
left.
So-
Regarding the differentials, you did not talk about differentials.
But because you initially rather prior asking you yourself nicely differential diagnosis narrated. So these gangrenous and also this may be this blood supply occlusion, maybe sometimes this cold extremity or vasculopathy, or this distal lesions you told. So these are these few
Differentials
apart
will
from.
be nicely given.
Yes. You started with this while describing this, you almost told all this gangrenous and this also vasculitis. And
Yeah,
this was
yeah. Thank you.
for this ossular nodes.
Okay, so we have some
Okay.
time left.
Move.
We can finish another video. So
Yeah, send the another video.
10 minutes are there.
It's my turn.
Yeah, you
Yes.
are a role player. Dr. Hiren will be.
Okay, so I'm sharing in the group the picture. Okay, it's a simple one.
No problem.
So who is the candidate?
Hiren.
I'm the candidate.
Okay, so just I'm telling the stem. This is actually a 6 months old Jack who is exclusively breastfed boy with a 3 month history of mild diarrhea and these rashes over the different part of the body which you can see. The okay, I think that's enough. So you just take your 3 minutes. A 6 months old exclusively breastfed boy with a 3 month history of mild diarrhea and these rashes over the different part of the body. The child is alert and the vital signs are normal.
Okay. Okay, so let's start.
Okay, so
Okay,
just elaborate.
yeah. So I can see in this picture, the child is a 6-month-old child who has a rash. It looks like erupted and macular rash on the face, on the neck, on the nappy area, on the both inguinal crease, and child. I would like to check the vitals and irritability. So you said vitals normal, and he's not irritable, right? And
Yes,
I would also like to check the rash on the back side, on the both the whole body area, which is the other part of the body, also has the similar kind of rash or not. Also, I would like to see whether there is any bleeding because it looks like red and kind of skin peeled off. So whether there is any bleeding is there or not from the rash, I would like to know. And yeah, I can also see some there is on the like right side of the body there is kind of a brownish spot. I don't know whether it's a shadow or reflection or what. There is a brownish greenish on the side of the chest, right side of the chest. Also, I can see that.
okay, that's a very good elaboration. So, depend upon all these findings, what do you suggest? What is your diagnosis? Most likely diagnosis.
Yeah. With the considering age, 6 month and 3 months history of diarrhea, it could be acrodermatitis because of the zinc deficiency. due to prolonged diarrhea. This is number 1 on the top of my differential, and the other differential, milk protein allergy, and kind of atopic dermatitis, which usually is the rashes are not classical with that, but this also I would like to consider as a second differential. And if there is, I would like to know whether there is any history of fever in a near duration, and any refusal to feed, and any uh, history of metabolic disorder. That also I would like to ask in the additional history.
Like which metabolic disorder? Anyone you can name?
This Leishman syndrome, and but this usually present later on. But pellagra and all
Okay.
this rash.
Very good. Very good. So, what will be the difference between pellagra rash and acrodermatitis and enteropathica rash?
Yeah, acrodermatitis and enteropathica usually nape area, and pellagra and Leishman usually there is a necklace area is involved more,
Excellent.
which here it is not there. It is present on the face as well as the nape area. So
Very good. Very good.
more
Okay.
consistent with the acrodermatitis and enteropathica.
Excellent. Okay. So your differentials were the atopic dermatitis, the metabolic problems, and the which was the third one?
The first one, acrodermatitis enteropathica. Second is
Yeah.
atopic dermatitis. Third one
Yes.
is Leishman syndrome.
Okay, that's very good. Okay, so let's suppose this is acrodermatitis enteropathica. So
And
what investigations like?
yeah, would like to do the stool analysis, general investigation like CBC and CRP
What what
to check,
what for stool
looking
analysis? What
for
for?
stool analysis for to see both whether there is any associated infective etiology is there, as well as the stool pH, and to also eliminate the possibility of secondary lactose intolerance, and level of zinc in the blood, and CBC for
Very
looking
good.
for nutritional deficiency, like for looking for anemia,
Very good.
and raised inflammatory markers like CRP. And
Great.
even I would like to do the albumin also to see whether there is any malabsorption.
hmm So, is there any one very cheap test which will tell you about the zinc deficiency? A cheap blood test, which we usually routinely, which we do for other things, and which give you a very good idea about the zinc level in the body.
I have no idea about that.
Okay, very good. That's actually the serum alkaline phosphatase, which will be actually low in zinc deficiency because this is a zinc dependent enzyme. Okay, very good. So, how you will manage this child?
So this child has to be managed with the, first of all, correction of the zinc deficiency with the supplementation of the zinc, local application for the rashes, like local antibiotic ointment, as well as some pain medicine like paracetamol drops if the child is persistently crying because of the pain of the lesion on the nappy. Try to keep that area dry and moist, and also if there is any dehydration or the element of milk protein allergy associated, also would like to consider special milk formula for that. And ORS supplementation also should be given if there is a evidence of dehydration.
Anything
And-
else
And
in treatment?
prebiotic and probiotic also, and zinc supplementation and
Yeah, this is
multivitamins.
zinc supplementation. It